Hello, my name is Ray Comenzo. I'm a hematologist and professor of medicine and pathology at Tufts University School of Medicine. In my practice, I'm frequently asked by patients and physicians what the limitations are of the current clinical trial data regarding the role of stem cell transplantation in the era of novel therapies for myeloma patients. It's important to look back at the progress we've made in the past 20 years. 20 years ago, the use of high-dose melphalan for stem cell transplant had not been shown to prolong survival in myeloma. Subsequently, 6 clinical trials were performed using autologous cells, that is to say the patient's own stem cells, initially collected from marrow, subsequently collected from blood with stimulation. And of those 6 trials, 5 of them showed significant advantage in terms of overall survival for patients who underwent stem cell transplant. Those trials were conducted prior to the era of the approval of thalidomide in 2000, the approval of Velcade initially in 2003, and the approval of lenalidomide in 2007, and certainly well before the approvals of carfilzomib and pomalidomide within the past several years. The trials, however, do give very strong evidence of the activity of intravenous melphalan against myeloma cells. And the initial studies done with intravenous melphalan in the 1980s showed a dose response. That is to say, as patients received more melphalan, more of their myeloma went away. Therefore, at this time, with these effective and less toxic therapies, the question clearly is, does stem cell transplant still have a role to play in patients who are less than 65 years of age and are eligible for dose-intensive therapy? Well, as part of standard practice, we answer that by saying it's a very safe and successful therapy. The mortality, the death rate associated with stem cell transplant in most centers is less than 1%. And patients do recover. They do experience improvement overall in the quality of their lives after treatment. There's ample data to support that position. However, we have to make our judgments based on clinical research. And currently there's a large trial being conducted in France and the United States, randomizing patients to get a series of therapies with novel agents, have their stem cells collected, and then continue those novel therapies versus initial therapy with novel agents, stem cell collection and stem cell transplant, and then maintenance after the transplant. So we'll have an answer as to whether or not transplant may benefit patients. A large study was done in Italy comparing patients who received oral melphalan and dexamethasone associated with the use of one of the novel agents, lenalidomide, to patients who received lenalidomide and dexamethasone and then went on to stem cell transplant. Both groups went on to receive lenalidomide maintenance. The patients who received stem cell transplant did better in that study. And I think that's the most current evidence that we have for an advantage to stem cell transplant. The other important point is that with novel agents, the French and the Hovan group in Belgium have been able to show in large clinical trials that the use of Velcade as part of initial therapy increases the overall complete and very good partial response rates and allows patients to undergo stem cell transplant and come out of their transplant with very, very high response rates, a very high complete response rate as well. So it may be the case that for the future, combinations of novel therapies with stem cell transplant, with consolidation after transplant, and with maintenance after transplant will provide transplant-eligible patients with markedly prolonged survival and very good quality of life. Thank you for your attention.